Hello, everyone. Welcome to this episode of Let's Talk Patient Blood Management. Today, we have a very important topic. We are going to be highlighting obstetrics, anemia, and hemorrhage. And it's a topic that's very close to my heart. I'd love to dedicate this episode to my dear friend, Naomi Amlin, who at the young age of 25 was a maternal mortality. She did not get to go home with her baby. And so we want to make sure, as a part of our education efforts to both medical professionals and to the public, to bring awareness to maternal hemorrhage and anemia and how we can do things to make sure that moms and babies go home together safely.
And thanks to Ecomed Solutions, the creator of HemoSaver, for sponsoring this podcast. They are very passionate about advancing patient blood management in obstetrics. In obstetrics, the HemoSaver enables clinicians to collect shed blood during vaginal deliveries and cesarean sections and return washed autologous blood to the mother. HemoSaver can be used for better recognition and response to blood loss, hemorrhage, and anemia. And at the end, we'll provide a link to more information about the HemoSaver. We're really excited about our guest today, right, Sarah?
Yes, we are.
We have with us today Dr. Katz. And Dr. Katz is an associate professor and vice chair of education for the Department of Anesthesiology, Pain, and Perioperative Medicine. Dr. Katz graduated from the University of Pennsylvania with a degree in economics, after which he completed his MD training at the Icahn School of Medicine at Mount Sinai. He also completed residency training at Mount Sinai, where he was a chief resident. Dr. Katz has research interest in two main fields, simulation as well as obstetric anesthesia. His specific areas of interest in those fields are novel educational environments, such as virtual and augmented reality in the domain of simulation and obstetric hemorrhage and viscoelastic testing in obstetric anesthesiology. That's awesome. Dr. Katz is also chair of the CPR and Resuscitation Committee of the Mount Sinai Health System. Welcome, Dr. Katz.
Thank you, guys. Thank you so much for having me. I can't wait to talk about all the exciting things that we're going to talk about in obstetrics, anemia, and hemorrhage.
Thank you for taking some time out of your busy schedule. We know you're so busy. I kind of talked about why this topic is important to me, but why do you guys think that this is such an important topic that we do some education, not only to medical personnel, but also to the public?
Well, I mean, to be honest, I think a part of it, and I hate starting on a low note, and that is, obstetric mortality. And that is, unfortunately, postpartum hemorrhage is the leading cause of mortality that occurs on the day of delivery. And unfortunate as that is, a lot of it is preventable. And with a little bit of prevention, we can hopefully prevent this from happening, hopefully completely, but at least decrease the incidence, because, the birthday is supposed to be the most exciting, amazing, and joyful day, in the family's life. And, to have a maternal mortality is it's heart-wrenching. And oftentimes it's preventable. Which is why something like this it's so important to discuss and talk about.
Yeah, I think too, when I was 25 and I lost my dear friend, the emptiness that happens when you leave a hospital with a child and not a mother is, and just the toll that took on the medical staff as well. That's heartbreaking. They don't want that to happen, and so the toll all around is just so enormous. And yet, now that I'm in the medical profession, I wasn't at the time, but there are things that we can do to prepare mothers, by optimizing them. And then there's things that we can do also, in the medical team that I have now since learned. And so I feel passionate about preparing mothers.
Yeah, there's so much iron deficiency that we see in pregnancy, delivery, even in the postpartum period. And iron deficiency and anemia are definitely associated with a variety of poor maternal and fetal outcomes. And when we know that and we look at that ahead of time, we could prevent a lot of the complications.
Yeah.
Yeah, I mean it's definitely, important to have that discussion where, like, and we'll talk about what happens on the day of delivery, but
Mhm.
there are things that we can control and there are things that we cannot control. And one of the things that we do have some control over is how prepared mothers are when they reach the place they're going to deliver.
Mhm.
And forgive my poor analogy to the hematologic system being a gas tank, but you really want to come in with a full tank. And
Yeah.
if you start at half a tank or less than that, then what would have otherwise have been a small minor issue becomes a critical life event. So the preparedness of treating these things preemptively, way in advance of delivery, to give everyone the best shot, is just, it's so paramount.
I love your analogy of the gas tank because it's so simple to understand. It makes a lot of sense. We're going on a trip of pregnancy and we know we're going to need gas to get there. And iron is what's going to fill the tank and help us out. So, how do we as medical professionals address these challenges and what can we do to ensure that the gas tank's going to be full and stay full and we're going to have a good outcome?
Yeah, well, there's a couple things that should be done. I think that obviously, following up with your care team regularly is important. There are, screening tests that are done to check for things like anemia. They'll check your blood counts. If your blood counts aren't where they want it to be, they'll send, iron studies that will tell you, whether or not you need to take more iron, whether or not you need more iron in your diet, and how effective, it can be at raising your blood counts. Unfortunately, if your iron stores are low, remember, now you need iron not just for you, right? You need iron for you, but also for your unborn child, right? Because they also have to, make the red blood cells, right? And the iron is, the critical component in the manufacture of red blood cells. So you need way more than you normally do. But if you're not getting enough iron, one of the first mainstay therapies is going to be oral iron or taking iron supplements. And in fact, oftentimes when, women are taking prenatal vitamins, there's some iron in there, but there's iron that's, they're asked to take above and beyond. The problem with, oral iron is sort of twofold. The first is that it not only does it not taste very good, but it also can cause a lot of GI upset, especially constipation. And so the ability of women to continue to take oral iron through the duration of their pregnancy is relatively low. Some women who have good insurance and they've got access to things like IV iron, and so they can go and they can get their counts up. Meanwhile, those who either underinsured or don't have insurance won't have access to this potentially life-saving tool. So we're sort of setting ourselves up for a bad time often when it comes to how we're going to actually measure and fix antepartum anemia. It all has to do with access to care.
Absolutely. And I know that many iron infusion centers are just overwhelmed with patients trying to get in there. There's patients with cancer and orthopedic patients and OB patients all fighting for spots. So even when with the best insurance and the ability to get there, it's still a challenge.
Yeah. And that's why I'm really excited. Recently we learned about the sucrosomial iron that popular in the EU, which is now available in the United States, because it is kind of giving us a middle ground option for oral iron and to alleviate some of those GI upset. And so there are options. We've just got to find the right option for the patient. What are some of the risks that we can identify beforehand that may let us know that a mother is at a potential risk for a hemorrhage?
So, well, I mean, there are things obviously that we spoke about screening for anemia because, peripartum anemia is already a risk factor for postpartum hemorrhage. But the risks for postpartum hemorrhage are varied. But if you think about it, they come down to, what are the common causes of postpartum hemorrhage? And the main cause of postpartum hemorrhage is called uterine atony, where basically after the baby is delivered. And you can imagine, the amount of blood flow to the uterus, at term gestation is enormous, up to a liter a minute, right? So after the baby comes out, that entire uterus that was, feeding the baby has to essentially shut down, and it has to clamp down. And the way it does it, the uterus is sort of like a muscle, right? So when it's relaxed and the blood is flowing, the baby's delivered, and now it's got to really contract, because when it contracts, it sort of clamps down on all that bleeding, right? So sometimes the uterus contracts very, very nicely. When the uterus does not contract, that is a condition called uterine atony, or an atonic uterus, where the uterus is relaxed and so bleeding happens. And so you say, okay, well, if a problem with the uterine tone or uterine atony is the most common, cause of hemorrhage, what are the risk factors for having uterine atony? And there are several for that as well. Basically, anything that's going to distend the uterus above and beyond a normal gravid uterus is going to have, risk with it for postpartum hemorrhage. Now, what extends the uterus? You could have things like, the amniotic fluid. You could have too much amniotic fluid, which is a condition called polyhydramnios. For those of you who have multiple gestations, right? If you've got more than one baby in there, their uterus is going to be, extra large. And then there are other things like maternal age, whether or not your pregnancy is an IVF pregnancy, what number pregnancy it is for you, because after a certain number of births, the uterus just can't contract as well as it did beforehand. Whether or not you had a prior cesarean delivery could have an impact on uterine tone. Whether or not you have a risk factor for having a part of your placenta stick a little too much to your uterus, right? That is also a huge, huge risk factor for hemorrhage that can happen. And, typically when people give birth, there's trauma that can happen to both the birth canal and to the uterus as well, or to the cervix, right? That is also a common cause of postpartum hemorrhage. But, risk stratification is certainly important, and it's a core thing that we do to women on the labor floor. They all come in, they get their hemorrhage risk screen, like as soon as they hit the door. And then while they're in the process of labor, we do what's called, an intrapartum risk screen, where we're looking, what's changed over the course of their labor that's made them, more likely to hemorrhage, who's at higher risk. But, the one thing that I think is important to impress upon everybody out there is that the most common risk factor for postpartum hemorrhage is no risk factors. So we can do, all the risk stratification that we want to and try to see it coming. But the reality is that most women who are going to experience a postpartum hemorrhage don't have any risk factors and are in theory low risk.
Right. So in some ways, I feel like the greatest risk factor is the team, right? Because really we have to be, how quickly can we recognize that it's coming at us? Like you said, most postpartum hemorrhages, if they had been screened, wouldn't have shown the risk factor at all. So we really just have to be very diligent and quick to notice and quick to react to that. How do we define maternal hemorrhage?
Yeah, so the answer is, like many things, it depends. So right now, if you're going by the American College of Obstetrics and Gynecology, which is ACOG, they're going to say that any, abnormal bleeding, or if you want to go by typical volume, it's going to be any bleeding above and beyond 1 liter of blood loss, irrespective of the mode of delivery. So whether you have a vaginal delivery or whether you have a cesarean delivery. Traditional definitions, and depending on whether or not you're going to follow the ACOG standards, will include vaginal deliveries where the patient has over 500 mLs of blood loss as qualifying as a hemorrhage, whereas here ACOG is just going to say it's abnormal bleeding, not necessarily a hemorrhage. But any blood loss above and beyond 1 liter would classify as a postpartum hemorrhage in terms of, straight definitions. But I think that there's, problems with those sorts of definitions, mostly because it's such a hard topic to make something that is dichotomous, meaning it's yes or no.
Mm-hmm.
Postpartum hemorrhage really is a spectrum of disease that depends on where people start up, where they're starting, what is happening during, and where they're going. So to simply say that it's based on a volume number I think is a little bit of a problem. It can be very problematic.
You're right, because if a mother came in with a less than full gas tank, right, she's going to be at peril much quicker. So to
Hmm.
just measure the volume out isn't a
Right.
true accurate measurement. I
It's a
like
great
that.
point. Yeah.
Exactly. And there's other things too that you have to think about. And that is, even if mom comes in with a full gas tank, right? You could have one mom who is, let's say, 4'10", who weighs, barely 100 pounds, right? Her blood volume is going to be very different from a mom who comes in who is, 6'2", is heavier, because just based on the sheer amount of blood volume that
Mhm.
people have, right? So which of those women, when they lose a liter of blood volume, is going to feel that more, right? That's not
Right.
accounted for in these types of protocols when it comes to deciding who has had a hemorrhage and who has not. So I think it's you have to define things, because if you don't
Hmm.
define them, you can't measure them, you can't really develop protocols and things like that. But I do think that we run the risk of oversimplifying a concept as complex as postpartum hemorrhage by saying, well, if you bled 999 mLs, you're not a postpartum hemorrhage, and if you bleed 1001 mLs, well, now you're a postpartum hemorrhage. I
Right.
think that sort of thinking
Yeah.
is dangerous.
That's a really good point. What I mean, certainly you do have some important indicators of maternal hemorrhage, signs that the mother's getting into trouble, and protocols. Can you discuss some of those indications and protocols for maternal hemorrhage?
Sure. So there's a bunch of different ones that you can use. Several of the obstetrical care societies have developed, care kits and toolkits. The one in California, the CMQCC, has a whole toolkit of how you can sort of run your hemorrhage protocol. Our own, New York Society has its own protocol. ACOG has a protocol. So there's lots of resources that are out there for people who want to design, what they're going to look out for when it comes to hemorrhage. But there are some things that tend to show up no matter which one you look at. By and large, the volume loss is going to be one of the main drivers of the response to a hemorrhage, namely talking about how much blood that mom is losing. Now, there's problems with that. Namely, it is very, very difficult to tell how much bleeding is occurring during the course of labor and delivery, right? For a couple reasons. So I would say one of the first ones is simply that there's a chaotic environment that's happening, and you have to first decide who is going to watch. So you have to assign a role of someone who's going to recognize the hemorrhage and keep track of the bleeding. The other thing to think about is, what are you actually watching, right? So it's not like a surgery where you're cutting and you're having bleeding and blood loss. You're also having to contend with amniotic fluid, urine, other bodily fluids, right? All these things are also coming out of the patient. So how much of what is coming out is actually blood, right? So a part of it is designing a protocol of how you're even going to measure blood loss. Traditionally, people have used visual estimation, which is just using your eyes. But lately, most societies have begun to recommend using quantification strategies, where actually you're going to be physically measuring how much blood is coming out. There's lots of different ways to do that. And I think, we could delve into the details. It may be a little bit, above and beyond the scope of here, but it's not as easy as just looking. Now, after you've measured, now you have to decide, what are you going to do about it, right? And then
Right.
there's lots of different treatment strategies for how you can begin to treat a hemorrhage. And part of it is going to be what you've already tried, and part of it is going to be what's going on with the patient. Now, this is where there's another sort of problem or issue, and that is, if you ask anybody what's going on with the patient, right? One of the first things they're going to say is, well, what are the vital signs, right? What are the vital signs? What is their pulse? What is their blood pressure? What is their oxygen saturation, right? These are we call them vital signs for a reason, because they're vital. The problem with obstetric hemorrhage is that moms tend to be generally young, generally healthy. Their hearts and their lungs tend to be very able to compensate for physiologic injuries, which means that once a mom starts to get tachycardia, meaning once her heart rate starts to become elevated, or once the mom begins to develop hypotension or low blood pressure, you're already in the throes of a severe, severe hemorrhage. You've already missed the boat. So
Wow.
like the tried and true thing that we like to use to tell us whether or not our patients are doing well, our vital signs are a late stage finding in postpartum hemorrhage. So you really cannot wait for those signs to develop. And if they do develop, you really, really, really need to jump on it. So these are part of the challenges when when you're dealing with something like hemorrhage. You at its face value look and say, how is it so difficult? Like, why does this happen? And it's because, it's hard to measure how much blood we're losing. Our normal ways that we measure patient well-being, by the time those start to get a little wonky, things are really, you're already really, really behind, right? Now, you look at the other stage, let's okay, well, let's just be hyper aggressive, right? Let's just throw everything at everybody. The problem with that is that all the treatments that we're giving also have side effects, right? Never mind the expense or the wasted resources, like whatever. We can put all that stuff to the side. They all have side effects, especially giving somebody something like a blood transfusion, right?
Yes.
You really, really, that can have all sorts of negative consequences. So you really only want to give a blood transfusion to somebody where, it's really going to help them out, where they're really going to benefit. And now you can see, based on all the things that we've already sort of mentioned, why it can be really hard to sometimes tell, which patient who's suffering from a hemorrhage is actually going to be the one that is going to benefit from a blood transfusion. Because, we could talk about volume loss in numbers, but the reality is that the body has gone through physiologic changes over the course of gestation. I think any pregnant mom or anyone who's had a pregnancy can tell you how swollen they feel,
Right.
Especially when you get to term, right? And part of the reason why this has happened evolutionarily is because the body knows that it's going to bleed. The body's trying to prepare itself for a hemorrhage. So as I said, most moms can have a blood loss and be okay and be just fine. It's not that every mom who bleeds or even has a hemorrhage is going to need, a blood transfusion or something like that. So discriminating who those patients are going to be, unfortunately, it's very, very easy to do in hindsight, but it's very, very difficult to do, when you're in the throes of having a hemorrhage, because those patients, they're really hard to identify.
How do you identify that you might be running into a problem without using the vitals as the first indicator?
So in our institution, we have a pretty rigorous quantification of blood loss protocol, where we use weights and things like that. The other thing that I think is super, super important of how our labor unit functions, honestly, is communication and taking a team-based approach to how we're going to handle hemorrhage, right?
Yeah.
So what does that mean, and what does that actually look like? It's very easy to say, everyone takes a team-based approach. But what does that actually mean? Okay, so who is on the team? So the team here is going to be our obstetrician or our midwife, the person who is delivering the baby. Okay, the team is going to be the peripartum nurses, and it takes a lot of people. I'm going to name a lot of people. Okay, it also takes the obstetrical anesthesia team, right, and all the ancillary and supporting staff on the floor. So that is the care team, plus the other support staff that are behind the scenes, your lab technicians who are running your lab specimens, your blood bank, right, who you're working on to get you blood products in a timely manner. They're all working together. But specifically when we're talking about making that decision as to whether or not you're in a problem, it's basically the people who are doing the measurements for the blood loss, the obstetrician who's watching to see what is the pace of bleeding, right? I would never expect an obstetrician to say, hey, tell me how much volume has come out, because honestly, they're trying to stop the bleeding, right? They're trying to do it. So they can say, we're bleeding, we're not bleeding, brisk, not brisk, right? The nursing team is looking around. They can see more of like a wider out view, right? They're still seeing close to the surgical field, but they're collecting the sponges off the field. They're looking what's in the calibrated V drape. They're seeing what's going on, right? And
Mm-hmm.
then the obstetrical anesthesia colleague comes in and they have even a bigger view, right? Because now they see the whole room. They can look and see, what does the patient look like? What are the vital signs? Just, not that they're going to tell us what's wrong, but are we already further behind them than we think we are? And everyone is sort of communicating to sort of figure out, are we in trouble? Are we not in trouble? Are we okay? And, do we need to escalate? Do we not need to escalate? No one person can do all of these tasks by themselves. It really does take everybody working together to really pick out that patient that says, okay, this patient started out, below where they should have. The bleeding is brisker. And, now we're going to go ahead and we're going to start to transfuse. Or is this a case where, yes, the obstetrician is saying the bleeding has stopped. Our nursing colleagues are saying we've collected, 1.5 liters of sponge material, and the vital signs look okay. And we can say, okay, we can, wait. We can wait, a couple minutes. We can draw another lab test and find out, what our hemoglobin or what our hematocrit is. And we can sort of trend things over time and, decide. We can wait and see a little bit more, right? So everybody working together, is important. And feeling comfortable to escalate when you think there's a problem, right? So it may be the case that one care team member is saying everything is going okay, and maybe to them, their perception, it looks like everything is going fine, but another care team member with a different perspective, may be saying, hey, we may actually have a problem here, right?
Mm-hmm.
And the comfort of a team member to be able to speak up and say, hey, we may have a problem here, is an important team dynamic that I think does lead to an enhanced, culture of safety, right?
Mm-hmm.
So when I say everyone has to be communicating, it's not just, playing a game of phone tag where one person says something and gets passed along, but it's the fact that, every team member is going to be watching and looking out for the patient. They have to feel comfortable, speaking up to say, hey, I think we have a problem, because if they don't, then they won't.
Mm-hmm.
And then, you miss an opportunity to intervene when, you could have, headed off a problem way at the beginning.
I also noticed in our previous discussion, we talked about different healthcare tools that an organization could utilize. And I felt like your program used a nice array of tools that not necessarily all obstetric units use. Could you talk to me a little bit about kind of going above and beyond and some of the tools that can make success stories?
Sure. So I want to start this discussion by first saying how incredibly fortunate I am to be, at a place like my institution where we have access to pretty much all the tools that anybody could ever want to help them, manage and care for these patients. I realize that many of the people who either are healthcare professionals listening to this podcast, are going to wish that when I say all the tools, are going to say, wow, I wish, we had this, on our floor. So, and for patients too. So this is also for patients. Like, I'm going to mention some of these things and, go online and learn about them, educate yourself, and talk to your obstetrician and say, hey, do you guys have that? And if you don't
Yeah,
have that, then ask them why. Because I can tell you right now, all of these tools that I'm going to mention cost money. And so one of the main things that can affect change when it comes to buying things that are potentially expensive is to have patients, saying that, hey, if you don't have this threshold of safety, then, I'm not going to choose to deliver here. I'm going to go and deliver somewhere else that does, right? So that's going to be
absolutely.
one thing
Yeah.
is you have to be an advocate, for yourself, and make sure that you have access to some of these tools. Now, what are some of the tools that I have access to? So I already mentioned our rigorous system for quantifying blood loss. I think that is an important system that not everybody has access to, but I want to just highlight, how important I think that is. The other thing is, having point of care testing for our electrolytes and for our hemoglobin concentration. So, one of the things that you may think about, what is going to determine when someone needs a blood transfusion. So a part of it is going to be dealing with their blood volume loss. But I already mentioned it's really, really hard to tell how much volume you're losing. It's really hard to determine, at what point you're going to need to start transfusing. And one thing that I think it's an important needle to thread, but something that, I'd like to sort of, bring the listeners aboard if you're willing to do this, is that when you think about blood, it's more than just red blood cells, right? There's other components to what is in blood. And I'm not going to get too deep into the weeds, but I just want to plant the idea that you can say there's blood, this is red blood cells, and then there's other stuff, the other stuff that's in there. Now, you can bleed out a certain amount of blood, and you can replace that blood with fluids that are not red blood cells, and you can restore the volume of blood, right?
Right.
But you could still have now a too low amount of red blood cells that your body needs, right? So you can have what's called, a low amount of volume, which is hypovolemia, or you can have a low amount of red blood cells, which would have anemia, or you could have both, or you could have neither, right? So one of the things that you will have to determine is when you're replacing the bleeding that is happening with IV fluids, right? Which are fluids, they're not red blood cells, right? You can correct the low amount of volume, the hypovolemia that a patient has. But you have no idea at what point you really need to start giving them specifically red blood cells to counteract the anemia, right? So one of the main tools that you are going to have is going to be measuring the patient's hemoglobin level, right? Now,
Right.
if you have a central lab to measure hemoglobin level, that means you're going to take a specimen from a patient, okay? You're going to send it through some system. At my institution, we have a pneumatic tube system. So it's like, you go to the bank and you put the thing and you shove it in, it goes whoosh, and it goes to the lab, right? Some places they don't have that. Someone actually has to, take the tube and run to the lab, right? Then they have to take the sample. They have to process it because they can't just run the sample on whole blood. It goes into a machine. So meanwhile, by the time you get your hemoglobin measurement back, it's been 45 minutes. Which, as you can tell from how things are going, I mean, it's too late. The number's already unusable, and now you know that you were either behind beforehand or you were okay, but you you had to wait too long, and now you've given a blood product that was unnecessary, right? So on my labor floor, I have access to a point of care blood gas machine, which means I draw a sample, I walk 5 steps over to my utility room, I stick it in there, and 15 seconds later, I know what the patient's hematocrit is, right? Which is essentially the percentage of their blood that is red blood cells. Now, it's not a perfect test, right? And there are issues with these, point of care, hematocrits. Don't get me wrong. And we can have a whole hour-long discussion about how they can sometimes be inaccurate and how you have to rely on things other than that. I understand it. We all have to see patients holistically. You have to take all the pieces of information and put them together to make a diagnosis. And I'm talking about these instruments as if they're one-offs, but they're sort of all taken together. But having access to that is important. The other thing to keep in mind with my point of care blood gas machine is that I get concentrations of all their ions. So things like their potassium level, their calcium level. Calcium is such an important ion when it comes to how much patients are bleeding, right? It's one of the vital cofactors in making your blood clot. So if your calcium level is low, your blood is not going to clot, right? So I can know whether or not I need to give patients, calcium, which having too much calcium is also really bad. So having access to that blood gas machine to give me the concentrations of ions and the concentrations of their, hemoglobin level, how much red cells they have, right, is super, super important. Okay, so that's one thing. The other awesome tool that I have access to is a point of care ultrasound machine, meaning that I have a dedicated ultrasound machine that's on my floor that I can use to take ultrasound images of a patient's heart, their lungs, and their abdomen. Whenever I want to have access to it, right? So one of the things that we said, it's really hard to tell based on the volume that's coming out, whether or not the patient is suffering from hypovolemia, whether there's low circulating volume. So I can put an ultrasound probe on a woman's heart, and I can check and see how well their heart is filling, right? Because after all, the heart is a pump, so I can see, is the heart empty? Is the heart full? How well is the heart contracting, right? Because you may have a change, like for example, somebody may have low blood pressure, right? Well, is their blood pressure low because there's not enough fluid in the pump? Or is their blood pressure low because their heart is malfunctioning? They have a problem with their pump, right? Those things are managed very differently. Well, with my echocardiogram machine, I can go and I can take a look. Now, it's not going to be as fine and fancy as if you go to like a cardiologist's office and they give you like all these precise measures. I'm not doing that, but I'm just saying, is the heart empty? Is the heart full? is the heart functioning well? And I can use that ultrasound machine and I can look at their lungs, right? Is there a problem with their lungs? Are their lungs filling up, with fluid, or do they have issues there? Or I can take a look in their belly and say, is there bleeding in the belly, right? So I have access to that ultrasound machine, which is expensive. And not only that, I have the special probes that I need to take a look at the heart and the lungs, which are typically, not found in your typical ultrasound machine.
Mm-hmm.
Okay. So the other thing that I have access to, which I also really, really love, is my point of care machine to tell me about coagulation. And I'm going to throw out a hugely complicated but awesome word, a viscoelastic test, which
Yes.
sounds really complicated, but it really isn't. It's viscosity is thinking about thickness, right? So I'm
Mm-hmm.
talking about how thick or how thin the blood is, and how easily or how difficult it is for the blood to form a clot.
Yes.
Now, why is that important? Well, it's important because obviously, if you are bleeding, one of the ways that you're going to stop the bleeding is to have your blood actually clot. And it does that by a variety of different mechanisms. We hold pressure, right? We actually, form clots spontaneously. There's lots of different ways in which our body can form a clot. Now, again, not to get too into detail, but I said, remember how the blood has red cells and then it has all this other stuff, that other fluid. And in that other fluid are your coagulation factors. And there's a lot of them, right? There's 13 factors that are just named 1 through 13. And then there's things above and beyond those factors, all of which help your blood clot, right? Now, there are certain ways in which, your blood clots that are a little bit different from another. And certain times you can have one area of your clotting be deficient, but one area of your clot is being okay. And so trying to figure out which areas of blood clotting your patient is having, problems with, allows you to give them the therapies that they need and not just have to give them everything all at once. So what I can do is I can rapidly identify a patient who is at risk for having problems with bleeding, and I can give them therapies in advance. And this is sort of like a similar situation to what we saw beforehand, which is where, most labs will have the capabilities of running some of these tests. But again, it means drawing the specimen, sending it to the lab processing it. And again, you're getting results, 45 minutes to an hour later, which in the world of postpartum hemorrhage is like you really too late, right?
Mm-hmm.
So on my floor, we have a point of care coagulation machine, that can be used to measure a patient's coagulation in very, very short order. I get my results back for my fibrinogen measurements, for example. So, there's lots of different ways, and I'm not going to go through every single one, but I will tell you that one of the most critical things that we like to measure in obstetric hemorrhage is this molecule called fibrinogen. And basically it is the glue that is what holds the clot together, right? So you have lots of different pieces, but this is like if you're going to think of like making pasta or something like that, right? This is the dough. Okay. So like you really need a lot of dough, right? So knowing how much dough I have really quickly is important, because as soon as that dough gets low, I need to know that I need to give more. And if the dough isn't low, then I don't need to give it. And, the blood products that we give that have fibrinogen, it's either a pooled product called cryoprecipitate, which is basically taken from a pool of donors, and it's a blood product. The other option is, fibrinogen concentrate, which is essentially a powdered form of fibrinogen, which I can also give, right? And I have different options for therapies. The fibrinogen concentrate is exceedingly expensive. And again, I don't want to get bogged down in price. We don't want to have discussions on price about whether or not patients get therapies, but as a whole, as a health system, that is something we have to be cognizant of, especially when it comes to waste. So I have this awesome expensive therapy. I need to know whether or not the patient's going to benefit from that therapy or not. So I need to know if someone has low fibrinogen before I'm going to give them a blood product that has fibrinogen in it. And the way that I can do that quickly and discriminately is by using this point of care viscoelastic test. There's no real other way to do it currently. So I can do that. So I've got, all these other tools that I have. And then I'd say probably the final tool that I would talk about, easy access to cell salvage. On my floor, I have the capability of giving back patients blood that they have lost that has been now collected and can be given back to them. And this concept of cell salvage or cell saving or autologous, cell salvage is a relatively new concept in obstetrics. Now,
Mm-hmm.
you think about it, it makes sense, right? You lose blood, you collect the blood, you give the blood back. Oh, and by the way, at the same time, our cell saver machines have gotten so much better at, filtering the blood, right? So we collect all the blood, which is the blood, the proteins, the platelets, the amniotic fluid, the irrigate, whatever else is in that mix, right? You all suck it up. It goes into the machine, and now what the machine does is it spins it around, and it puts it through a whole process. So now all we have left are the red cells, right? And a little bit of other, stuff. And then what we're going to do is we're going to take that and we're going to pass it through another filter. And this filter is going to be, a specialized filter that's going to take out, fat containing molecules and other proteinaceous molecules that aren't red cells. And what's going to get through, it's going to be, some other things, but it's going to be mostly red cells. The amount of other stuff in there is going to be really, really low. And maybe that is going to be enough to not cause problems. And so some places, in cases where you had patients that couldn't receive blood products. So, for example, patients who refused blood products, right?
Mm-hmm.
Who say, I would rather die than have a blood product transfusion, right? So in those sorts of patients, it became worthwhile to attempt it, right? And so people started to try to use cell salvage in the obstetric population. And as time went on, they said, this fear of us having it, it's not happening. And so they started to use it more. And then we got more data. And so people used it more. Now we got more data. And now there are institutions, for example, one of my colleagues at UPMC, Grace Lim, John Waters, I mean, they're now using it routinely.
Mm.
And not only in their cesarean deliveries, but also in their vaginal deliveries too. Not in every patient, they save it for their hemorrhages, and we could talk about what are the mechanisms, how we actually go about doing cell salvage.
Mm-hmm.
But the idea of using cell salvage in obstetrics as not as a high risk thing that should only be done in the most dire of circumstances, that's relatively novel.
Yeah.
So the fact that we have access to something like that on our floor, and that we have people that are in house pretty much 24/7 to do that is also a thing, right? You can do all the cell salvage you want, but if you don't have somebody to process the blood and give it back to the patient, well, then what do you really do? So I'd say I have access to all that sort of stuff, which again puts me in a very advantaged position for managing something like a postpartum hemorrhage.
So returning mom's blood back to her makes sense. It absolutely makes sense. Why don't most organizations use it?
So there's a couple things. So part of it is, again, the expense, right? These cell saver machines themselves are expensive, but most major hospitals, if they do major surgery, will likely have a cell saver machine. Okay. The cost comes into play, a lot of it with who is going to do the processing, right? Which may have to be a perfusionist, but can be other people. Other people than perfusionists can do cell salvage because it's not as complex as running, a bypass machine or an ECMO circuit or something like that. But the other expense and time consuming effort of it is the insert, right? So the insert that goes in has to be sterile. It has to go through a collection process. It's fairly tedious to set up and requires the presence of the cell salvage machine, right?
Okay.
So you have to have a cell salvage insert in a cell salvage machine, which means, remember, as we said on the labor floor, who is at a risk for postpartum hemorrhage? Everyone,
Everyone.
right?
Yeah. Yeah.
So like you can't put a cell salvage machine in every room. You also, can't really have like a couple cell, and you're just like, could you imagine like just running around all over the hospital anytime someone is bleeding, carting this machine? It's not a small machine.
Right.
I wish I had a picture of it that I could show you guys, but it's a hefty machine. It's a cart on wheels that you can push around. It's just logistically, it's really, really hard. Okay.
And certainly you can't have the perfusion staff, at all deliveries.
Correct. You can't have that
there's
either.
usually
Yeah.
a minimum amount of perfusion staffs and highly used in other, specialties. And so I can see that being, is there a cost effective way of incorporating cell salvage into your obstetrics with, eliminating, how do you work around those costs?
Right. So there is a solution that we've utilized on our floor to sort of get around it. And basically the idea is, you can collect the blood in some sort of a container, right? And then hold on to it and see if, you first of all, if you collect enough blood to be processed. And then if you do process it, going through the whole rigmarole of the cell salvage and then giving it back to the patient, right? Now,
Mm-hmm.
what is that kind of a device? What does it look like? Well, there is a device that we utilize at Mount Sinai. It's called the Hemosaver, and basically it is a canister that has a sterile insert. So the outside is like a plastic shell. The inside is a sterile insert, so you've met the sterility requirement. And basically, you can collect blood from the surgical field or from the surgical drapes, and it can be held in that canister for, depending on whether or not you refrigerate it and the circumstances, 6 to 8 or even more hours in
Oh,
that
okay.
canister. And so, basically, what you do is you put some anticoagulant in there, right? Because if you don't put anticoagulant in there, then the blood will clot, right? And then you
Mm-hmm.
can't salvage blood
Use it.
clot, right? So you put the anticoagulant in there, you collect the maternal blood, and then you can run testing on it, right? So there's a port on it that you can suck out a sample and you can say, okay, how much of this liquid that's in there is actually blood, right? And then if there's a decent amount of it that's blood and you have a patient who is at a decent likelihood of needing a blood transfusion, I can now say, okay, now I'm going to call my perfusionist, bring the cell salvage machine, open up the, fancy schmancy insert that costs, I don't even want to know how much money. And now we can actually go ahead and use the cell salvage. So, it gives you the flexibility and decision of where you want to deploy cell salvage, but you don't necessarily have the resources. I mean, look, I told you the stuff that I have access to. I'm probably one of the most resourced obstetric anesthesiologists in the world,
Mm-hmm.
right? And even I don't have access to, cell salvage machines and perfusionists 24/7, right? So the
Right.
fact that I could collect the blood, hold on to it, and when I know I run into a problem or running into a problem, call for those resources to come and process it and then give it back to the patient, that allows you to do it in a cost effective manner, right? Because most patients aren't going to need it. And the canister relative to the cost of a perfusionist and an insert is pennies on the dollar.
Okay. And do you use that canister liner, then the Hemosaver, in every single delivery, both vaginal and cesarean? How do you differentiate?
So if I had my druthers, I would use it for every delivery. Unfortunately, though, we don't have the resources to do that currently. But what we do
Okay.
have is sort of a risk stratification, right?
Mhm.
So people who are a high risk, we use it. If
Mhm.
we start to encounter, so remember how I said like early detection is key, right?
Right.
So part of the PPH protocol is when you're in the early stages and you've identified somebody, even though they don't have risk factors, but you're just in there and the obstetrician is saying, we're bleeding more than we think, right? Part of that first stage of reaction is to say, okay, bring in the hemosaver canister and start collecting that blood,
Okay.
right? So
Very
not for
good.
everyone, but as soon as there's been a recognition of a problem, we go ahead and we start to collect.
Okay. Very good. So some of the tools, again, let's just review them because it was kind of lengthy. We want to
Sure, yeah.
educate the public. And so what tools should they ask their facilities? So I heard, do you have point of care testing, right?
Yes, for both, ions, hemoglobin, and coagulation, ideally. So you can just say, do you have a point of care blood gas machine? That would be the thing. Do you have a point of care blood gas machine?
Okay. And do you have cell salvage ability? If I'm
Yep, cell
losing too
salvage
much
capability.
blood, are you able to give me back my own blood?
Mm-hmm.
And what were some of the other tools that we discussed? There was
Yeah,
several.
so I
Oh,
would say that
ultrasound
the
machine.
an ultrasound machine, right? An ultrasound with a cardiac probe, or people who are trained to do ultrasound, point of care ultrasound.
Mhm.
And then the point of care viscoelastic testing. And if you don't want to say point of care viscoelastic testing, you could say, do you have access to either a TEG, a ROTEM, or Quantra, or something similar to that? Those are probably the mainstay machines that you may have access to.
And do you have a way of measuring my blood loss other than just I eyeballing
Visual
it.
estimation, yes. Do you
Yes.
quantify? Do you quantify bleeding? Do you do? And the fancy term that they'll understand is QBL. Say, do you do QBL?
Yes. Perfect. Thank you so much for taking the time with us. I know you're busy. This discussion has just been phenomenal. I feel like I have I've just gained so much in just listening to you. For final takeaway, what would you like to tell our audience, whether they're medical or whether they are the public, that you feel is very important takeaway today?
So I'd probably say that this is something that, it takes a village, that everybody has to really be on the same team. And if your plan for postpartum hemorrhage, started at the time of a postpartum hemorrhage, then you need a new plan. So for patients out there, be advocates for yourselves. Start early, right? Get tested, get checked, talk to your healthcare team, right? Make sure that they've got all the resources that are in play before you're going to your delivery. For those of you who are out there who are part of the healthcare team, advocate for your patients. Try to get them access to the best testing modalities that you guys are able to bring on site. Don't just accept that when people say, oh, we can't or we don't have access to that just say, okay. Advocate, push, right? Continue to push and advocate, for your patients. For those of you who are on the labor floor and you're working, practice your hemorrhage plan, right? Think about what is going to happen at each of those stages and what other tools you're going to bring into the mix to do it, and use the resources that are available to you to go ahead and plan for how you're going to manage those patients. And then finally, one thing to discuss, at least, partially, is we realize that sometimes, regardless of how prepared we are and how awesome of a job we do, that these events unfortunately do occur. And so, make sure that you are taking care of yourself. If you are either a part or a witness to this event, or a healthcare provider who has witnessed this event, don't think that the feelings that you're feeling are abnormal. And, even if it's not going to be a mental health care professional that you go and talk to somebody about it. You are not
Mm.
alone. Your other healthcare workers are there to support you, and everybody wants you to be well. So just realize that you're not alone, and get the help that you need.
Mm. Thank you so much, Dr. Katz, and thank you to Ecomed Solutions and the makers of HemoSaver for helping us to get this education out to the public.
It's been an absolute pleasure having you here on the podcast. Thank you so much. We hope you enjoyed this conversation and found some takeaway or new thought that improves your health. We would love to hear from you. Feel free to reach out to us on our website if you'd like to see what we're up to. Our website is letstalkpbm.com. If you enjoy our conversations, please like and subscribe wherever you listen to podcasts and on our YouTube channel.
Special thanks to our guest and our producer, Delaney Coronado, and the entire production team for all of their expertise in content creation, technical abilities, and dedication to our message. We appreciate the experts who drive this medical movement forward, and our affiliate partnerships who support the work that we are doing. Until next time, stay connected to your blood health.